So the vote stands at 8-3. You need a couple more votes, and we'll leave that open for you, and we'll go on to your next bill.
I'll start while they're.
Pardon?
I can go ahead and start while they're switching.
Sure,
up.
sure. That's great.
Thank you, Mr. Chair and members. Let me start by accepting the amendments outlined in the mock-up provided to the members. With the amendments, we're working towards an agreement on the primary concern noted by the plans, and I'm grateful to you and your staff for working on this bill with me.
Thank you.
AB 2372 improves access to care for Californians living with HIV by requiring health plans to include HIV specialists within their networks and providing a pathway for HIV specialists to serve as primary care providers for their patients. While current law requires plans and their networks to include access to medically required specialists, what we found is that plans are relying upon infectious disease specialists to serve their beneficiaries with HIV. Certainly, every HIV specialist is an infectious disease specialist, but not every infectious disease specialist has the certification and or training to provide comprehensive care to people living with AIDS. We need provider networks that can meet the needs of beneficiaries, and we should allow HIV specialists to serve as primary care providers for their patients. With this bill, we can deliver better, more coordinated care for Californians living with HIV. I will continue to work with the stakeholders as this bill moves forward, and I respectfully request your aye vote.
Thank you.
Mr. Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation, the sponsor of the bill. I want to thank the author for carrying it and for the stakeholders, including the plans, in working with us to resolve some issues. We've actually made substantial progress, especially on the issue of PCP. But let me just point out that as things have evolved in the AIDS epidemic, one of the things that has been always of a concern is access to care for people with HIV, to professionals who actually know how to care for this very unique disease. Prior to the Affordable Care Act, we had a pretty robust network of HIV specialists that were funded largely under the federal Ryan White Care Act. When ACA came into being, that took over primacy in terms of providing care. Unfortunately, the networks did not maintain always the same level of HIV specialists that we had under the Ryan White Act. What we're seeking to do with this bill is try and restore some of that so that the people with HIV can actually get care from the people who do know how to provide that care. The other piece of this bill dealing with the primary care physician, HIV is now a managed care condition. People have it for decades now. Their HIV doc tends to be their doc for many, many years. And they provide a variety of services to them, not just related to HIV, but also all of their primary care as well. The reality is, though, that the HIV specialists are not always allowed to be the PCP. We would like to have that be an option for the HIV specialist to be the PCP as well, so they can provide all of the care for the person with HIV. And with the agreements that we've had recently with the plans, I think that issue has been resolved, and we continue to work with the plans on the other issues as well. Thank you.
Great. Thank you very much. Others in support?
Catherine Austin Scott with the California Academy of Physician Assistants. We appreciate the amendments and look forward to giving you a letter of support.
Thank you. Anybody else in support? Opposition? Is this a good side of the table or a bad side?
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We appreciate the work the author and sponsors have done on the PCP and the most recent amendments. Unfortunately, we are still opposed to the bill. The way that it's drafted, and specifically creating a subspecialty requirement for our network adequacy standards, this would mean that we would have to adhere to a max travel time of 60 minutes or a max travel distance of 30 miles. This as the CHBRP noted, there's only about 900 of these specialists in the state of California. We understand that they're positioned more regionally. This would potentially invalidate the majority of our networks as not being able to meet these standards. And that creates a considerable concern for the plans. So with that, we'd like to continue the dialogue on this issue. I'm not sure if we can get someplace on it, but we'd certainly like to continue to be open with the author and the sponsor on this. But at this point, we remain opposed to the bill.
And Jennifer Alley with California Association of Health Plans. I'd like to echo the comments made by my constituent here, and we are going to continue our dialogue, but we're very uncertain how we can meet all of the goals in the bill, but it's something that we'll bring back to our membership and continue the conversations.
Great, thank you very much. Others?
Yeah, John Winger on behalf of America's Health Insurance Plans, also opposed.
Great. Comments, questions from Mr. Gomez?
Ms. Burke, I just want to say I like your work on this issue. I really appreciate it, and it's always hard for me to vote no on your bill, so I'm going to vote aye today. Thank you so much.
The bill has been moved and seconded. Any other questions or comments? Ms. Waldron?
Thank you, Mr. Chair. Just briefly, as principal co-author, I was excited to see this bill. As we know with HIV, getting the best treatment up front is the best way to get control of the disease so folks can have a more consistent and healthy life. And that's why it's important that we have the ability to have HIV specialists be PCPs. Thank you.
Any other comments or questions?
Real quickly?
Sure, Mr. Lackey, of course.
Just for the record, I hear a lot of terminology used, PCP, that's not phencyclidine, right, that we're talking about?
Yeah, thank you for bringing that up. I was just going to bring that up, I'm hoping that people in the audience are listening to the entire conversation and realize we are not talking about angel dust. So, thank you. Thank you, Mr. Lackey. Appreciate that. Wow, with that, would you like to close?
No, I think Assemblywoman Waldron's close was perfect. I think it's important that those suffering with HIV actually have a good quality of care, and to get that, they need to have a specialist. I respectfully request an aye vote.
Great. Thank you very much. Appreciate you bringing this forward, abbreviation or not. I would like, the bill has been moved and seconded. The motion is due pass as amended to appropriations. Madam Secretary, please call the roll.
Wood?
Aye.
Wood, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye, too. Dababne? Dababne, aye. Gomez? Gomez, aye. Hernandez? Lackey? Lackey, aye. Nazarian? Olson? Olson, aye. Patterson? Ridley Thomas? Rodriguez? Santiago? Steinnorth? Steinnorth, aye. Thurmond? Thurmond, aye. Waldron? Waldron, aye.
You enjoy a vote of 12-0. You're the second bill to get out today, so thank you very much. For those of you who weren't watching TV earlier, Ms. Bonilla is going to be going next, and then it will be followed by Mr. Gordon, who appeared, and then Mr. Gallagher. So, Ms. Bonilla, you have a couple of bills before us.
I do. Thank you so much, Mr. Chair and members, for the accommodation so we can get this voted on. I want to begin by thanking the committee for all their work on this bill. I really do appreciate it, and we will be accepting the committee amendments. I'm happy to author this important bill, which is co-sponsored by the California Medical Association and the two oncology associations in California, ANCO and MOASC. Today I present AB 2209, which requires accountability and transparency when a health plan develops and implements a clinical care pathway. Clinical pathways have been in use by doctors for over 25 years. They create a standard of care for numerous diseases and conditions. Pathways use clinical evidence and the expertise of doctors to spell out specific treatment plans for patients with a specific disease. However, some health plans have now begun to develop their own pathways, stepping out of their traditional role as a business entity and a role of payer for insurance, and they are now making specific treatment recommendations to doctors. As such, my bill would put forward the fact that they should be held to a certain level of transparency to benefit the patients, the doctors, and the public. The bill does three things. It ensures pathways are developed with transparency, with a basis in the best science. Secondly, it prevents a health plan from mandating provider participation in their pathways. And thirdly, it prevents pathways that discourage clinical trial participation. And as if you remember, I'm a huge proponent of trying to expand clinical trials. This bill also defines a clinical pathway. The definition focuses on two questions. Who uses clinical pathways, and what are clinical pathways ultimately used for? Clinical pathways are used by doctors to aid in the determination of a patient's course of treatment. Health plans do not use pathways, even though they may develop them. The pathway themselves are not used by health plans to decide what drug or service they would choose to include as a covered benefit. This is what is captured in the bill's definition of a clinical pathway, and we will continue to work with the health plans and patient advocates to clarify the definition and address any additional concerns they may have. AB 2209 requires health plans to disclose their entire pathway development process, which is the scientific studies used to develop the pathway, the summary of evidence gathered after reading the scientific literature, and the names and any conflicts of interest for anyone who is involved in that pathway development process. For years, doctor groups and hospitals have developed pathways, and they have done it in this transparent manner. Now that health plans are developing their own pathways, we must make sure that they too are held accountable and are transparent. With me today, I have Dr. Dan Mira, President of the Association of Northern California Oncologists, and Fred Noteware.
Thank you, Madam Mr. Chair and members. My name is Fred Noteware, and I want to compliment the author for encouraging this bill and working collaboratively with us, and Mr. Chair and your staff and others on this committee. This is a very timely conversation, because what's happening right now is, for the first time that we know, a health plan or health plans are seeing themselves somewhat in the role of a provider, and they're giving guidance on how to provide treatment decisions, albeit through their process. And all we're trying to say is that may be a good thing or a bad thing, but what we want to know is how they do it, and let's hold them to the same standards that exist for other clinical guidelines development. And so Dr. Murder is here today, and thank you again.
Good afternoon. My name is Daniel Murda, and I'm a practicing oncologist in the greater Napa Valley area. I'm also president of the Association of Northern California Oncologists, ANCO. On behalf of my organization, ANCO, and the Medical Oncology Association of Southern California, I urge your support for AB 2209. Clinical care pathways, or pathways for short, are detailed and specific care plans used to direct the care of patients with a specific disease. When developed and implemented correctly, pathways can provide physicians and their patients with the best and most current evidence-based treatment for their disease. Up until recently, pathway development has been led by practicing physicians in a transparent, evidence-based manner that prioritizes clinical effectiveness while minimizing treatment side effects. If multiple treatment options remain after this type of analysis, then, and only then, should one consider the comparative cost of the remaining options in selecting a pathway. We have recently seen health plans step out of their traditional role of payer and step into the role traditionally held by physicians, making specific treatment recommendations to physicians via pathways. When my colleagues and I began to explore the development of these health plan developed pathways, we were only able to find the pathway itself. No specific information was forthcoming on the panel of experts that developed or advised the health plan in the development of this pathway. No detailed information was forthcoming on underlying analysis of the medical literature used to reach the recommended pathways, and in short, it was not possible to evaluate why the pathway was being recommended for my patients. AB 2209 will ensure that the best practices used by physicians in the development of pathways and endorsed by the national organization, the American Society of Clinical Oncology, will apply to health plan pathways as well. There is nothing in AB 2209 that keeps a health plan from developing clinical care pathways. It simply asks that the health plan pathways to be transparent and evidence-based, and to prioritize clinical effectiveness, minimize side effects, and then and only then incorporate costs into the clinical decision-making on behalf of patients. Physicians working on behalf of and with our patients in making critical healthcare decisions need to be able to determine if a recommended pathway is based on the best evidence. If physicians are being asked by health plans to use specific treatment plans via their pathways, it is our obligation to ensure that those treatments are in the best interests of our patients. Physicians need your support for AB 2209 to ensure that we can continue to put our patients' best interests at the center of this clinical decision-making. Thank you.
Great. Thank you very much.
Nisette Short on behalf of the Medical Oncology Association of Southern California, one of the co-sponsors in support.
Great. Others in support?
Jerry Jeffy, representing the California Chronic Care Coalition, in support of the bill.
Thank you.
Tam Ma with Health Access in a tweener position. We appreciate the amendments that the author has taken, and we continue to look forward to continue working with our office on this bill. Thanks.
Okay. Anyone else in support? Opposition? Please come on up.
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans in opposition to 2209, even with the amendments that are going to be taken today in committee. Just by way of background, members, thanks to medical innovation, there are more cancer treatment options than ever. However, research shows that there's a very significant variation in treatment practice patterns and quality of care. For instance, up to 1 in 3 people treated with chemotherapy do not receive a treatment plan that is consistent with current medical evidence and best practices. Research has exploded in recent years, with as many as 180 medical journals publishing new studies on cancer monthly and quarterly, making it difficult for practitioners to stay up to date on the latest evidence-based medicine and on an increasing number of treatment options. In addition, huge variations in costs can exist for equally effective treatments. For example, the 6 first-line regimens for non-small cell lung cancer range from $450 to more than $60,000 in cost for 3 months with no difference in outcomes. All of these are reasons why health systems, drug distributors, and health plans, among others, have developed pathways for cancer treatment. Pathways are voluntary programs aimed at helping providers ensure their patients get clinically appropriate, quality care with minimal side effects. Let me emphasize, they are voluntary. Pathways, at least the voluntary pathways developed by health plans, do not interfere with doctors deciding which therapy they believe is best for the patient. They also do not interfere with innovation or clinical trials. They are simply one of many ways in which the healthcare system is trying to develop more evidence-based treatment programs and options. CAP opposes AB 2209 because it unfairly singles out health plans and subjects their pathways and programs to unneeded government regulation. It assumes a need for statutory guidelines without imposing those same standards on other pathways that are developed by other entities. The proponents have demonstrated no evidence that singling out health plan pathways is warranted for regulation, nor have they demonstrated a problem that they hope to fix with the bill. Why should only voluntary health plan pathways be subject to the standards of this bill? The proponents themselves stated in their opening testimony that they believe that the health plan pathways should be held up to the same standards as other guidelines. Well, then if that's the case, then everybody's guidelines should be, pathways should be subject to the standards of this bill, whether it's a health plan, drug distributor, or a medical system. You know, isn't it reasonable to think that a pathway developed by a drug distributor might prevent access to clinical trials of a competitor drug? It's not clear at all why the standards proposed in this bill would not be applied to pathways developed by others. We should place the same standards on pathways in clinical drug trials in which providers are paid by the drug makers for participating. Quite frankly, that situation sounds more troublesome than a voluntary set of guidelines. So this is just one of the concerns that we have with the bill that we believe is unnecessary, which basically takes a scientific, evidence-based process and interjects a level of undue influence. Simply put, AB 2209 deters the development of evidence-based treatment programs, and as such is a step backward for the health system, and we respectfully oppose the bill for those reasons and others. With me today is Dr. Jennifer Malin of Anthem, who developed Anthem's Cancer Pathways program and can answer specific questions about how pathways programs work.
Thank you. Thank you, Mr. Chairman, and members of the committee for the opportunity to provide context to our program and answer questions. In addition to being medical director for oncology at Anthem, I'm a clinical professor of medicine at UCLA and continue to see patients at the VA hospital in West Los Angeles. Our Pathways program, or Cancer Care Quality Program as we've named it, was developed because there are big gaps that have been documented in the literature in terms of care that has been summarized in the literature and studied and what is actually delivered. Just today, an article was published that showed that half of the women over 65 with breast cancer who have HER2-positive breast cancer and should be receiving the life-saving drug Herceptin do not receive this therapy. There are other examples throughout the literature. For example, only 10% of bladder cancer patients receive the treatment of BCG or mitomycin after surgery to remove the tumor, even though it has been shown to dramatically reduce recurrence rates. And yet, one more example, less than a third of women with ovarian cancer get intraperitoneal chemotherapy. So the basis for our program is to provide pathways that highlight these very important therapies and high quality and high value therapies for our members. As has been already said, the program is voluntary. Providers are always, physicians are always making the decisions with the patients in the room. The health plan is not involved in that decision making. I just want to take one moment to provide context for why we as a health plan decided to become involved with developing a pathway program rather than relying on some of the ones that are out there in the community already. And this was because none of the programs that exist publish their pathways. They consider them their intellectual property, and they will not make them publicly available, including ones that are currently in use by MOASC, one of the sponsoring organizations in Southern California. So we felt that it was absolutely imperative for our members and our provider community that our pathways be publicly available. The evidence summaries are available to anyone who emails us and requests them, and have been since the inauguration of the program almost 2 years ago. So with that, I will close my comments and look forward to any questions.
Thank you very much. Others in opposition, just your name and organization, please.
Chair members, Luis Sanchez with Blue Shield of California in opposition.
Teresa Stark with Kaiser Permanente in opposition.
Sherry McHugh representing the California Chamber of Commerce in opposition.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies in opposition.
John Winger on behalf of America's Health Insurance Plans, also opposed.
Okay, anyone else? Anybody in between? I'll bring it back to the committee for questions or comments. Ms. Olson.
Thank you, Mr. Chair. I appreciate the author bringing this forward and what I think your intent is, which is to make sure that cancer patients and other patients have the best access to care. I very much support that goal. I've been a long-time supporter, and my record will show that I, too, believe cancer patients deserve access to the very best treatment possible. Having said that, I've been spending time reviewing your bill and looking at the supporting arguments, the opposition arguments, and I'm struggling with whether the bill as written is achieving that goal. Because it seems that, if I understand things correctly, the clinical pathways that are being recommended by the health plans aren't required to be followed. There's no mandate that the treating physician follow those clinical pathways. So I would think that the more people we have developing evidence-based clinical pathways, the better, because it gives more choices for a physician to consider when they're treating the individual patient. So perhaps the question's to you or the opposition or the supporters or maybe everybody to help me understand why you think the requirements of this bill would result in better treatment for the patient, because I would think as long as the final decision-making authority lies with the treating physician in consultation with the patient, that more options are better than fewer.
I would agree, and I agree actually with a lot of the statistics that were presented here. I think the point of the bill is about, is it evidence-based? And if it is evidence-based, the doctors would like to know that. That's what the bill does. It's really not an onerous requirement upon the plans, and there's nothing in the bill that says they shouldn't be developing pathways. What the doctors want to know is it evidence-based? Who did it? And where are the studies? That's what the bill does.
And I could appreciate that. But to the opposition's comment, should we apply that standard across the board then? So whoever's developing the clinical pathway, should they have to abide by that same standard?
That's already the best practice standard out there. The doctors, the hospitals, the process that is in place is completely transparent currently. We're asking the plans who are new to this world to come in really alignment with what doctors and researchers have been doing already.
There seem to be comments to the contrary, but maybe the proponents can clarify.
Please.
If I can clarify it a little bit too, as I stated, in exactly as you said, when there are situations that there's a lot of different options for patients, the question we've had to the plans, and any plan that would put forth a single recommendation in that process, is how did you make that decision? That's what's really lacking in the process, and then when asked, we've not been able to get that information out. And I think that we deserve to know that one recommendation of essentially 3 or 4 equivalent options, or sometimes more, a lot of times, is that based on something other than what we see in it as an evidence-based process. So really, our question has been not to prevent pathways from being made, because I think they are. We've used pathways for years now. And the real thing is, how was it decided? And at least we know, yes, this is cost effective. ASCO has already done that exact same thing with comparing costs based on various equivalent pathways or guidelines. So we really think a pathways approach should include that information to those that are being given this recommendation, but we don't know what the recommendation is based on.
One comment and one question, and then I'll move on. My comment would be, I don't disagree with the concern of the desire for the information. I believe it was suggested that when the physician requests such information, that information is provided. But I guess my concern would be heightened on that issue if it was a requirement that the physician provide the recommended pathway. And since it's not a requirement, it's not a choice, or it's just a choice, excuse me, I think it's a slightly less concern. And then my question is, an example was given, was it MOAS, offers clinical pathways and also doesn't, it was suggested anyway, also doesn't provide the information that is being requested by this bill. So could you comment on that, and do all the others who recommend certain clinical pathways to treating physicians disclose the exact same information that's being asked of the health plans to disclose?
So MOAS had a pathway, they no longer have one, so that's not actively an issue. All the other pathways that Dr. Murda referenced that our members are aware of are all those ones that disclose the information, tell exactly who was on the panel, any conflict of interest, all of that information is disclosed. And one of the distinctions is that it doesn't just say, here's one study that shows that this drug was okay in this situation. It really does say, here are all the studies that explore this issue in this context, and the reason we picked this one is because of this analysis. So it really is much more in-depth information that doctors are really looking for in terms of making that right decision for their patient.
Okay, thank you. I don't know if the opponents have additional comments, but I appreciate you bringing this forward. I agree with what we're trying to accomplish, and I'll watch it closely moving forward.
I will just state it simply. I'm sorry. Just state it simply. The bill only applies to health plans. I mean, we're happy to hear that they think there's transparency with respect to other entities that develop these pathways, and they should be a part of the bill.
Agree. I think that'd be a great amendment.
Dr. Malin has other background on that.
Yeah, no, I think also it's important to clarify the distinction in transparency between the names of advisors, so names of individuals who provide advice on pathways programs, which some of the other programs do report, versus actually even making the pathways public. So for all of the other programs, so Cardinal Health, which is a drug distributor, has one of the leading programs that MOASC was using. McKesson, which is another drug distributor, has a program. Via Oncology, which is another spinoff of UPMC. These are the main pathways developers so far in the United States, and you cannot find actually what the drug regimens are that are in their pathways. They will not make them available. They would only make them available to individual physicians if you sign, basically a non-disclosure agreement, and not to, anyone in the public. So our pathways are publicly available, and we make the evidence information available to everyone, including both the boards of the oncology associations who are here today have had meetings with me where we've publicly provided them all of the detailed reference material on the pathways.
Mr. DeBobney.
I applaud the author for the work in this area, but I am too have to express sentiments very similar to Ms. Olson and very confused by, you said best practices, but is it in statute?
It is not in statute.
It is not in statute. So there are groups of other entities that are providing pathways that would not then have to follow the same standards, even though by definition from the argument here, you said it's best practices, but not everyone follows best practices.
Well, do you want to speak to that?
Well, I'm not done with my question, but my follow-up question would be, I think everyone's dancing around this. I'm new to this committee, but in every letter I got in support of this bill, it said that they're basically want to